Hello everyone, welcome to HIM 216. This will be the first of several lectures covering Chapter 2 in your textbook. If you would please turn to page 11 in your textbook, and I am going to use some PowerPoint slides for this lecture since we're not working in 3M, but I'm also going to be asking you to follow along in your textbook. As we look at page 11, you can see the information about what we'll be covering in this chapter, and we're covering quite a variety of things. We're going to be looking at the different sections in a health record. We're going to be looking at UHDDS guidelines for assigning principal diagnoses and procedures. We're also going to look at queries and review what a query is. Then you'll notice we have abbreviations and acronyms at the bottom of page 11 and also at the top of page 12. Again, I encourage you to take some time and go through and look at these abbreviations. You will hear me use them in the lecture, and then you'll also find them throughout the chapter. One of the things that I always tell my in-person classes, and I'm going to tell you, is that I've been doing this a very long time. I've worked in acute health care for over 30 years. So there is almost like a language of its own that we use in healthcare regarding abbreviations. Abbreviations are commonly used, for instance, for a patient that has chronic obstructive pulmonary disease. We call it COPD. Caregivers will write COPD. So hypertension is written as HBP very often. Chronic kidney disease will be written as CKD. So very often you need to have an abbreviation book handy, and of course you can find that reference online so that you can look up abbreviations that you find. And there are abbreviations that I have come upon in coding in some of the case studies that we'll actually be doing next semester, and I have no clue what those are. They are in a context that is not in an area that I coded extensively in, and I'll go look them up. There is nothing wrong with looking up. As a matter of fact, when you're learning to code, and even as an experienced coder, you are continually learning and you are continually looking things up. There are certain resources that we look at all the time. We're constantly in the CMS.gov webpage. We look at the American Hospital Association Coding Clinic. Coding clinics come out quarterly. As a responsible coder, you have to read those. They're actually referenced in 3M so that if there is a coding clinic reference that's applicable to a code that you're reviewing, you need to go and read that. So we do a lot of reading. I always tell HIM students, if you don't like to read, this may not be the best course of study for you. So basically, we're going to begin talking about the health record as the foundation of coding. And in HIM, we say, if it's not documented, it's not there. Some of the challenges sometimes with clinicians learning to become coders is that they know about disease processes, and they'll say, well, if the patient has dry mucous membranes and poor skin turgor, they're dehydrated. Well, we may know that, but if the physician doesn't document that the patient is dehydrated, we can't code it. We may look at an x-ray, or we may look at a radiology finding, and in the inpatient setting, we can't just pull a diagnosis out of those and code them. We need physician cooperation, or we need for that particular x-ray to provide more specificity to the documentation from the physician. So one of the important things we have to remember, if it's not documented, we cannot code it. Now, when we're talking about a health record, oh, and let me also say this, you are responsible for the content in the chapter. I will not in any of these chapters go over every single thing in these chapters. I expect you to have a certain reading level, a certain capacity for understanding, and there's information in these that if you read it, I don't go over it, you don't understand it, well, you need to get in touch with me and let me know so we can go over it. That being said, every time you have gone to a healthcare provider, they have created a record for you. They create a record for a number of reasons. One, they're required by law to create a health record. That record is their legal business document. You have learned that in 115. The record also does other things. It clearly demonstrates the quality of care. And it also is supporting documentation for charges. So the health record is extremely important, and it must be maintained in conjunction with the legal and regulatory guidelines and requirements and laws for that particular type of provider. And so that's where HIM comes into HIM comes into play. One of our areas of expertise is knowing from a legal and an accreditation and a regulatory standpoint, what documentation do they have to have? Now, in this course, we're primarily looking at inpatient requirements, inpatient coding, inpatient documentation. As you look through this textbook, you'll notice that we have a chapter on reimbursement. That's actually the first chapter that we will cover in your next coding course. There's also one chapter on outpatient coding. All the rest of the chapters in this book primarily deal with inpatient coding. So there's much more of an emphasis on inpatient coding than outpatient coding, particularly in this textbook. Does that mean outpatient coding is not as important? Does it mean that it's easier? No, it does not. It's just very different, and it has different guidelines. Now, when we're looking at a health record, anytime a patient presents for care, they have to have a health record. There are instances where physicians have been investigated by maybe the State Board of Medical Examiners because they were treating family members. And usually what happens is the medication they are prescribing is a controlled substance. The State Board of Pharmacy, the State Board of Medical Examiners come in and investigate them and find out that they don't have a patient record that backs up their treatment, and usually it's a family member, and it's someone that they have seen on the cuff, provided a prescription for, and then the patient's gotten it filled, and maybe there is some question about it. If there's a pattern or a trend that the State Board of Pharmacy sees, then they may report it to the State Board of Medical Examiners. So providers must have a record for every patient they treat, and it's just a requirement. The goals of that document are pretty much the same regardless of the setting, regardless of whether it's an inpatient or an outpatient. That record should document the patient's health history. It has to be done timely. You don't wait for a couple months after you see a patient to go in and do your documentation. It needs to be very timely. And then there are some key elements that every record should include. You need to be able to identify the patient. You should have their full name. You should have other information that we refer to as demographic information, which is the patient's name, their phone number, their address, their social security number, their employer, their health insurance information, their date of birth, their sex, their race. All of that is demographic information that is collected on a patient. And if you have ever been to a healthcare provider, you know that what they are asking you for. You're familiar with that requirement. Now, and actually I'm on page 12 in your textbook. One of the other key reasons for that health record is a communication tool for clinicians. Now, in a physician's office, if it's a multi-specialty practice, you may not see the same physician every time you go. So you want Dr. Smith to know what Dr. Jones did, to know what Dr. Davis did. That record is that communication tool. And of course, it's the legal business document for that provider. And also, it says serves as a resource for healthcare practitioner education. And of course, that does actually depend on the setting that you're creating that document in. In your textbook, it talks about, in that very first paragraph, Abdulhak's textbook, she talks about the 5 purposes of a record, and then on down it talks about CMS, and they have provided physicians with general principles of medical record documentation, and you can see all of those items listed. One of the things that you're going to learn is that CMS and their requirements drive healthcare. And why is that? Because CMS and federal payers are one of the largest payers of healthcare in this country. And the federal government wants to make sure that their beneficiaries are getting excellent care for an excellent price. And they pretty much drive healthcare. Pretty much whatever CMS comes out and says they're going to do, other providers tend to follow in their wake. So we're very focused on what CMS says and what they do because they are one of the primary payers of healthcare. On page 13, your textbook talks about, and by the way, these PowerPoints are actually available to you in course content, and so you'll be able to see those there. Now, when we talk about the different sections of the medical record, we have administrative data, then we have clinical data, and we also have the demographic data. The administrative data does include demographic data, all the personal information about the patient, all the different consents that the patient has to sign for their care. There's a general consent to treat, then there's the HIPAA notice of privacy practices, then there's the consent that you sign that says what your insurance company doesn't pay, you'll pay. All of those go into a section of the record that's called administrative data. Then the next section of the record is clinical data, and this is the documents, the data created by the healthcare providers. Now, this data can be electronic, it can be paper, you can have some of them that are electronic, some of them are paper. The format doesn't matter. The documents are the same. An H&P, whether it's a paper H&P or an electronic H&P, is the same. The requirements are the same. The content of that document will be the same. One's in a paper format, one's in an electronic format. The transition for people who have worked with a paper record and transition to an electronic record has only been challenging learning the new technology, because the documentation requirements, the content, the forms have all stayed the same. As we've implemented electronic health records, you haven't seen states make changes in their requirement for record content or for how long that data has to be maintained. None of that has changed. The only thing that has changed is the format, whether it's paper or it's electronic. The information is the same. So for those of us in HIM, it really has not been a difficult transition at all. Instead of flipping through a piece of paper, we're flipping through computer screens. Your textbook talks about the different types of documents that we will find in a record, and one of the things that you need to realize is the entirety of that health record. Every piece of information in that health record is data. And if you're looking at a paper record, you can go through and read it and pull out all the data. You can go in and review 50 records to determine what the sex of those patients is. You can look at what the ages of those patients are. You can look at what their principal diagnosis is. You can look at the medications they were treated with. Everything in that record is data. When it's created electronically, those data fields are all able to be queried, and you can run reports and generate reports. So even that functionality is the same in the electronic world as it is in the paper world. It's just a whole lot faster and easier in the electronic world. So in the paper world, if I wanted to know what my top 10 diagnoses were for inpatients, chances are I would have had a billing system that maintained that information. But if not, I would have maintained a disease and operation index, whether it was electronic or whether it was in paper, and I could manually create that report. In an electronic record, I still maintain those types of indexes and I can generate reports, but I can do it a whole lot faster. Now on page 13, it talks about the different forms that we will see in the chart. Typically, this is not every form. These typically are the reports that we will use to code this record. Now, when we start learning about coding, you will learn that we use the entire medical record to code from. We read everything from front to back. We can read any nurse's notes that are there. We can read dietitian notes. We can read social worker notes. All of those documents in that record have the potential to impact the coding of that medical record. The ones we absolutely must look at are the documents that are created by the physicians and maybe any physician extenders. So let's start by looking at the emergency room record. And on page, actually on page 14 in your book, this is the Uniform Hospital Discharge Dataset. UHDDS is what we call it. UHDDS actually defines the definition of a principal diagnosis, secondary diagnosis, principal procedure, and secondary procedure. And those data elements are mandatory requirements for reporting. You will also find on page 14, of these 20 items that are listed, these are all mandatory reporting, and there actually are many, many more than this that UHDDS requires. When we look at this list, not all of these come from HIM. For instance, at the point of registration, they gather much of this data. They assign an account number. They enter the date of birth, the sex of that patient, their ethnicity, their admission date. The nurses on the floor typically enter the discharge date. Admitting will put in the attending physician. In HIM, often we are abstracting and entering the operating room physician. We determine the principal diagnosis, the other diagnoses. You'll notice that says qualifier for other diagnoses. External cause injury codes, we assign those. Procedures and dates. Disposition of the patient. HIM doesn't assign the disposition, but we verify it. And then expected source of payment and charges. Actually, source of payment comes at the time of registration, and then charges are a compilation of all the charges that are entered by all the departments that provide services to that patient. On page 15, we can see an ER record. Now, I'm not going to read all of these documents to you. I can read most of this particular ER record. You can see definitely why it would be very advantageous to have an electronic health record, because not all of this is extremely legible. There are abbreviations used that can be challenging if you're not familiar with it. But basically, this is a typical example of what an ER form looks like. And in HIM, we would review this and we would code this. This is absolutely information that we would use to help us apply the official coding guidelines and the selection of the principal diagnosis and the principal procedure. You can also see that this document continues on to page 16. Every patient gets a history and physical. If you look on page 18, the next few pages are an example of a history and physical. And there are actually state, federal, and regulatory guidelines for the completion of an H&P. Basically, an H&P has to be on the chart of an inpatient within 24 hours. It has to be on the chart before a patient goes to surgery unless it's an emergency. Now, the next document that we have, and this H&P actually goes on to page 21. If we look on page 22, this is an example of a paper order sheet. In an electronic record, orders are put in electronically. This is a paper document. And so the physician writes the orders. And I want you to notice this second order, 10/19/00. You'll see there's a date and a time. And you can see that this says done. And that is where the nurse has signed off on this order, saying that, and what that means is that she actually transmitted to the lab the physician's orders to attain a urinalysis with a urine culture, a C. diff, fecal leukocytes, and lactoferrin level on this patient. And if you think about the process of how orders happen, the physician writes the order, but then someone has to alert the department. If it's not an electronic system where the orders flow right over once they're put in, then there has to be a way to tell the department that there's an order. Same thing with medications. And in a paper chart, you could have a paper chart and then orders are entered electronically by the nurses when they're signed off, or you may have the nurses filling out request slips that are then hand delivered to the particular department that has to perform the service for the patient. There's an example, if you look on page 23, this is an example of an electronic printout of an order form. And these have been put into the system, and then this order form has been generated electronically. It may be that if I have an electronic record and my patient comes in and they want a paper copy of it, this is what their order form would look like. The next document that we have as a progress note, it's on page 24. Physicians are required to write a progress note daily, and that progress note needs to include some specific information. It needs to include how the patient's doing, how they're responding to treatment, and if there's a change in the assessment or the plan for that patient. There's another example of a progress note on page 25. This is a SOAP progress note. If you look on page 26 at the top, this is a medication administration record. And actually this is a form, would be a paper form in the chart that nursing would fill out. The medications that are ordered are in the system electronically. The form is filled out and then nursing completes it as they administer medications. At the bottom of page 26 is an example of a lab report. And pretty much all lab reports, the equipment used to complete lab work generates these reports. And for at least 25 years, these are the type of reports that have been on medical records even prior to electronic records, because the lab equipment was electronic. Any patient who has surgery has to have an operative report, and actually you'll find a On page 32, you will find an operative report, and you'll notice that it includes the date of the procedure. There is a pre and a post-operative diagnosis. Then there is a list of the procedures that were performed. And oftentimes you will find surgeons that will include the estimated blood loss in this top narrative portion. In order for a patient to have surgery, they have to have anesthesia. And if you look on page 27, 28, 29, 30, and 31 are very good examples of anesthesia forms. Anesthesiologists are physicians. They assess the patients before they administer anesthesia. Anesthesiologists can stop surgery. If they evaluate a patient and they decide that that patient is not a good candidate for anesthesia and surgery, they will say, no, I am not going to give this patient anesthesia. What are some of the things that might impact that? Usually they are medical conditions. If a patient is a diabetic and their blood sugar is too high, if the patient has a cardiac condition and they haven't been cleared by a cardiologist, if the patient just has any type of arrhythmia or heart rhythm rate that hasn't been previously diagnosed and treated, anesthesia can say, no, I'm not going to put this patient to sleep. I want further evaluation on them before they are anesthetized. Now, of course, in cases of emergencies, those things kind of go out the window. You know, if you have a patient that's bleeding to death, you're going to give them anesthesia and you're going to do the surgery to try and save their life. So these are not hard and dried and fast rules. For elective procedures, yes, you know, if I go in and I want to have a tubal ligation and my blood pressure is 200 over 120, no, they're not going to do that elective procedure. But if I'm having an emergency and I'm hemorrhaging and my blood pressure is 70 over 40, yeah, they're probably going to go ahead and do surgery anyway and give me the fluids and blood I need to get my blood pressure up. Now, if you look on page 29, this is intraoperative monitoring. They just have to continually monitor patients, and you can see that these patients are monitored about every 15 minutes. Look at all of the documentation that's in this room. On the bottom right hand corner, what time did the patient come in the room? What time was anesthesia ready? What time was anesthesia started? What was the time of the incision? So anesthesia looks at from the time they started anesthesia, how long was it before they cut? What time was surgery finished? What time did the patient leave the operating room? So there is just tons of information on this form. You can see it includes estimated blood loss, urinary output, just tons of information that anesthesia gathers as part of their monitoring process. Anesthesia was probably one of the last areas to be put on an electronic record, and it's easy to see why, because of the intense documentation, all the equipment that has to be used to monitor this, the interfaces that have to be built, all to go into an electronic health record. So a very complex process. If you look on page 33, you'll see an example of a radiology report. So once a study is completed in radiology, ultrasound, nuclear med, they generate a report, and the radiologist, the physician who is interpreting this, looks at that report, he reads it, we say that he reads it, and then he dictates his findings. If you've had an x-ray done before, staff that are specifically trained in how to take those x-rays and how to use that equipment actually take it. They take the picture, they do the ultrasound, and then the radiologist looks at the images and then he generates a report. So depending on the type of report. The physician may be more involved. If it's anything that involves a radioactive isotope or anything like that, the physician may be more involved with the procedure, but typically specifically trained staff take those films and the radiologists read them. Recovery room report. Part of that anesthesia report that we looked at included the recovery room record. The anesthesiologist, it's on page 31, the anesthesiologist actually has to follow that patient into the recovery room. They have to make sure they wake up. Once they may leave the recovery room and go to a room on a patient floor or outside the recovery area. The anesthesiologist has to see them again and say, yes, they're good, they're ready to go home. And patients really can't leave until the anesthesiologist sees them. Now, in some outpatient settings, physicians do their own anesthesia. For instance, in a cardiac cath lab, the cardiologist may do the anesthesia. Nurses specifically trained in sedation, conscious sedation, may administer that. The physician's responsible. Same thing in GI labs, but those patients still have to be evaluated before they leave. Now, the next document that you will see on page 34 is a discharge summary, and patients are required to have a discharge summary. One of the purposes of that discharge summary is to recap the course of treatment for that patient while they were in the hospital. What did they come in for? That's what history of present illness represents. Why did they come in? What was their hospital course? How did they do while they were there? And okay, now they're leaving, so what's their discharge diagnosis? What medications am I sending them home on? Are they supposed to be on a special diet? What activities can they participate in? And when are they supposed to come back for follow-up and see the physician? So those are all elements that are supposed to be included in a discharge summary. I've seen many discharge summaries that basically were 3 sentences. Patient came in with chest pain, workup was negative, sending them home, follow-up as needed. Activity as needed. Activity ad lib, meaning whatever the patient would like to do. So those are that's kind of a quick review of the documents that we use in coding a medical record. If you look in your workbook and you get to chapter 8, once we start in chapter 8, then the workbook, and we're actually coding, the workbook has case studies. And those case studies are excerpts of medical records that include real data. So certainly I encourage you to go and look at that data. You'll also have more exposure to medical records as part of the AHIMYS eHIM virtual lab and the electronic records that are available in the virtual lab. Now, your question for this lecture is, I want you to look on page 35, and you're in exercise 2.1. I want you to answer questions 5, 7, and 9. So basically you will, in this, you'll open up this assignment, and you can scroll. There's a place for you to enter information. Don't put it on a Word document. Just type it in the assignment and then submit it. Now, for number 7, it says, where in the record would you find the chief complaint? That's what document. In what document in the medical, or documents in the medical record, would you find the chief complaint? So we're going to end here on page 35. If you have any questions, please don't hesitate to let me know. Thank you.